If you would be so kind to walk people through now the genes and the discussion of these three particular candidates that we're discussing relative to diabetes.
What we're going to talk about today are three genes that have a relevance at different stages in the development of diabetes, the management of diabetes, or the consequences that may happen. So, whether you have additional issues like cardiovascular disease or stroke risk, those sorts of things that are exacerbations as a result of diabetes. So TCF7 is a gene that was discovered a number of years ago, and it was discovered in several very large surveys in the United Kingdom and in Scandinavia. And what TCF7 is it's a transcription factor. So when you look at how do you read and how do you interpret the DNA, we have a number of additional proteins that help to make that read clear and understandable. And one of the things that gets done is transcription factors are responsible for turning on and turning off a given gene. So you get a signal from the body, you get a signal through the cell, and it turns on the transcription factor, and it tells your cell to make a certain protein, or it tells your cell to stop making a certain protein. So the discovery around TCF7-L2 is that it turns out right now to be perhaps the susceptibility gene with the largest impact on the development of diabetes. And the reason for that is that TCF7 regulates the expression of insulin. So this is a transcription factor that does most of its work within the pancreas, and it turns on or turns off the expression of insulin. So if we were to take this transcription factor and increase its function, so basically you get a gain of function. So we turn it on and we over-rev it. What you end up seeing is you get a stimulation in the secretion of insulin. And conversely, if we were to shut it down, if we were to silence it, you would get a reduction or a suppression in the amount of insulin that's produced. So if you have a variation in this particular gene, you may be incapable of properly regulating the expression of insulin. So when you need the insulin, your body can't turn on enough of it to compensate and to do its biological function. And by the same token, if you've got too much of it, then your overproduction of insulin is going to cause you problems physiologically as well. But, this is just one factor in the development and the management of insulin. As you've probably heard from Dr. Brewer, there are a multiplicity of things that can go wrong and can lead to the development of insulin. It could be something like this, where there's a mistake or mutation or dysregulation in this transcription factor. It could be antibodies that you produce against the cells that produce the insulin. So if for type 1 diabetes, for example, there is some evidence out there that we produce autoantibodies against the cells that produce insulin. So there's a number of factors that go into developing diabetes, and this so far is turning out to be one of the strongest ones. The unfortunate thing is that very few labs, if any, are running this now on patients for clinical interpretation. So, if you had a history of diabetes in the family, or if you just wanted to know, do I have an increased risk? There are very few places to get this test, but the test does have a tremendous impact on determining whether you have a higher risk of developing diabetes. It's one of those check marks that says this is wrong, this is wrong, this is wrong. And that could be diet, it could be autoantibody production, it could be transcription factors, it could be a mutation in your insulin gene where it just doesn't produce like it should.
Right. Now, pardon me for interrupting, but it's a good time to point out the term epigenetics. We use that. Many people may have heard that, but that's a good illustration. You discussed turning the switch on, turning the switch off. So just because you may have a transcription factor 7 doesn't necessarily mean, it doesn't guarantee you may or may not develop diabetes. You may overproduce or underproduce insulin, but it's that epigenetic event. And by that we mean what? That you do things that make it more likely to turn on.
There are things that happen to us over the course of our lifetime. So we start off with a genetic profile, and sometimes that genetic profile has a mistake in it, a duplication, a deletion, a mutation. But then on top of that, we have an additional set of regulation that happens that comes as a result of environment, for example. So epigenetics could be things that happen because of diet, because of environment, because of chemical exposure. And most of the time, epigenetics is the addition of a methyl group. So that methyl group gets on top of the gene and can artificially turn it off. And it doesn't allow the transcription factor to come in and do its job. You can kind of think of us as one really large system of switches, on and off switches. And both of the two proteins or the two genes that we're talking about here to begin with, TCF7 and ATM, are both switches of sorts. So they help to turn on or turn turn off, and they have to be regulated by other outside influences. They're regulated by glucose, they're regulated by epigenetics, they're regulated by environment. So, having all of these switches going on and off continuously to turn on and turn off things means that we have an exquisitely complex physiology that most of the time works really, really well. It doesn't have too many glitches in it, but occasionally a glitch develops, either an inherent mutation or alteration or as a result of epigenetics because we've been exposed to something that turns the switch off or turns it on.
Like pancakes.
Yeah. So TCF7 is a very strong genetic component. I don't think there's anything out there that seems to refute that it has a role. It's got a very powerful role. It's been looked at in a number of different populations around the world, and all of that research has held very strong that there are areas within this particular transcription factor that have a dramatic effect on the pancreatic beta cells, and that impacts insulin secretion. So you turn off that transcription factor and you lose the ability to properly secrete insulin.
And that's what we're doing when viewers hear us talk about a Kraft insulin score. You're really trying to see that whether it's because of a predisposition with TCF7-L2 or something else, we're trying to get a view of that in real time. And the Kraft insulin score, for those of you who have done it, with OGTT is another term for it, but the Kraft is more of the view of what is happening in the OGTT, the insulin, the glucose study. So we pound a person with lots of glucose by having them drink that nasty glucola drink or anything with high amounts of fructose or glucose. And then we have a fasting score, so we get a look at what is your glucose level, what is your insulin level at baseline fasting. And then you look 1 hour, 2 hour, and sometimes 3 hours. And so, for instance, you're saying if you have this transcription factor 7, it's very likely that depending on whether it's revved up or revved down, you're either going to oversecrete insulin, so you get an overreaction, which has one physiological impact. Most of the time, what we're seeing with people with diabetes is they're undersecreting that insulin, and so their blood sugar levels continue to remain high, which continues to impact the inflammation cascades that occur in their bloodstream.
Right. We end up having significant damage as a result of that high sugar.
And we're trying to, with Kraft, we're scatter charting and looking at 0, 1, 2, 3 hours and looking at 2 or 3 different parts of the sea salt over oversimplified. If it takes an enormous amount of insulin, a large reading of insulin in order to affect that glucose, that's telling you one thing. It's also telling you if your insulin response is normal and your glucose level is normal, then you're not insulin resistant. But if you cannot produce enough insulin or you overproduce insulin but still doesn't change your glucose rating appropriately, then we get a good feel of your insulin resistance or your full-blown type 2 diabetes.
Right. There's this balance we have to try to keep between the glucose level and the insulin, right? There's this continuous biofeedback. And these 2 first genes are participants in that biofeedback. So this is the first one. If you are essentially a normal, healthy person, you don't have any real issues back and forth with, too much glucose or too much insulin or vice versa. You could use TCF7 to determine, do you have a risk? And that means you could do something proactively, right? You could say, all right, I know I had a risk. It's one of maybe several, but these are the things that I can do to proactively alter the possibility of becoming insulin resistant or becoming diabetic, one with a diagnosis of diabetes.
So I'd like to talk with you a minute about the webinar. People don't understand what the webinar is. It's actually a great way to get some access to healthcare that you're just not going to get any other way. You actually get the lab tests yourself at a local lab, a Quest lab near you, for the inflammation panel and the OGTT and the insulin survey. These are things, inflammation and prediabetes, that your doctor just does not know about. And here's the thing. Harvard Health and many others have said, look, sudden death is not always so sudden. The Hollywood picture that it's a bolt out of the blue is not realistic. It's more like real lightning, preceded by clouds, wind, and rain. Stop that metabolic storm before the lightning strikes. And here's where that metabolic storm comes from. It's inflammation, and it has to do usually with prediabetes. So again, we actually get labs, we go over them in the webinar, and then you can start finding out how you can prevent that heart attack others said that you couldn't even predict. we can show you how. Thanks.